Hi, I'm Emily Kongs, and I'm a speech language pathologist from Oklahoma City. I'm excited to have this opportunity to share about motor speech disorders and Down syndrome. I've been an SLP for 15 years, although I have to confess my passion for the field has completely changed in the last 5 years. My husband and I have 3 kids, and in 2016, our youngest daughter, Madeline, was born with Down syndrome. And Madeline has really reignited my passion for the field of speech language pathology. Though I spend much of my time researching and learning about speech and language and Down syndrome, Madeline has been my ultimate teacher. She is the one who has taught me far more than I've taught her, that's for sure. Like most of you, we have worked through a few challenges in her short 5 years. First, her heart surgery at 3 months old. Then she had a lot of issues with hearing, and we had to advocate for appropriate testing and amplification early on in her life. You can see there in that picture, she's wearing her Baha, which is a bone-anchored hearing aid. And that was probably one of our first hurdles that we had to get over to help her with her speech and language skills. And now her motor speech challenges is what we really have spent a lot of time focusing on, and that is what has brought me to my current line of research and learning. So I'm hopeful I can help other families by sharing what I've learned about motor speech disorders and how motor speech disorders relate to Down syndrome specifically. All right, so let's get to it. Let's talk about what is speech and why is it difficult for people with Down syndrome. So we know speech is a complex motor task. Movement is required to speak. Speech is continuous movement gestures from one posture to the next. It requires planning, executing, and coordinating movements. And speech requires the subsystems of respiration, the lungs and the diaphragm, phonation, the voice box or vocal cords, articulation, which lips, tongue, jaw, teeth, palate, those all help with articulation, and it's a planned motor task. So we use our brain to plan and program speech movements. So this is a slice of the brain called the motor cortex, and neurons in your motor cortex are grouped by body part along this cortex. Interestingly, at least I thought it was very interesting, is that the parts that require that fine motor movement, like your hands and of course your face, they take up as much space as the arm, the hip, the trunk. If you'll look at the illustration, you can see that the hand takes up as much space just about as the trunk to the hip, which I think is really interesting. So why is speech difficult for some people with Down syndrome? These reasons are different for each individual, and some individuals have all of these risk factors and some don't. But the research does show us that there are specific factors for reduced clear speech in people with Down syndrome, and they've kind of divided them into categories. So the first one is in the cognitive linguistic domain, which means that people with Down syndrome, of course, we know they have differing IQs. Their IQs are inconsistent and they vary throughout the lifespan. Of course, we know that IQ tests aren't the best representation of our child's abilities. Also, they have short-term memory deficits. People with Down syndrome often have a hard time sequencing speech sounds, and this can affect speech development. They have a hard time remembering the particular sequences of speech sounds for words, and we call this phonological memory. You may hear phonological memory deficits. We hear that a lot. Craniofacial differences, both oral structures and functions. Structural differences often include a small oral cavity with a high, narrow, arched palate. And these differences are thought to account in part for poor speech intelligibility due to dysarthric factors such as reduced speed, range of motion, and coordination of all the articulators. They may have diminished sensory motor performance, meaning they have their sensory ability in the oral mechanism, so in their mouth during chewing and swallowing. The awareness is decreased. They may have decreased awareness of bolus size, so the size of the bite of their food in their mouth. They may have a delayed initiation of swallow and laryngeal penetration due to not feeling the residue. So we call this aspiration, right? The role of sensory processing, though, in speech development and speech performance is not well understood. Then hearing, right? Hearing affects approximately 2/3 of children with Down syndrome, and they can experience conductive hearing loss, sensory neural hearing loss, or both. Hearing loss can affect one ear or both ears, and it can range from mild to profound. Children with Down syndrome are particularly susceptible to otitis media, fluid in the ear, and this is possibly due to narrow auditory canals and craniofacial differences. So what is a motor speech disorder? We've said that a few times already, and I think it might be important to give you some definitions. A motor speech disorder. So motor speech is just a general term referring to the process of planning, programming, and executing the movements needed for speech production. A motor speech disorder, or sometimes called speech motor disorder, is a cover term used to describe motor speech sound impairments such as apraxia and dysarthria. So why do we, the people who love, care for, or treat those with Down syndrome, need to know about motor speech disorders? Well, I kind of shared a little bit about our experience, but I'll tell you again that our experience was that as Madeline continued to grow and develop her speech skills, we could tell she had a really hard time at certain tasks. She worked her way through the imitation hierarchy, meaning she could imitate movements and gestures. She babbled and produced jargon. You know, she was continuing to develop her speech. But when it was time for her to cross the bridge to imitation of speech, it was really, really hard. She could not easily imitate my speech or her sibling's speech. She even had trouble with those very simple syllable shapes like words like up. She struggled with imitating those. So that's when I started to research more and came across lots of valuable research that we're going to talk about today. So when I started doing a lot of research regarding motor speech disorders and people with Down syndrome, this study by Wilson and colleagues in 2019 just really hit me when I saw that 97.8% of people with Down syndrome met the criteria for motor speech disorders. They took conversational speech samples of 45 adolescents with Down syndrome, and 97.8% met the criteria for motor speech disorders. They included childhood dysarthria, 37.8% of the sample, speech motor delay, 26.7%, childhood dysarthria and childhood apraxia of speech, 22.2%, and childhood apraxia of speech, 11.1%. And the most prevalent dysarthria subtype that was seen was ataxia, which we'll talk a little bit about that later. But so what does this mean? Like, why was this so alarming to me? Well, mainly because just like the research tells us that specific to treatment, the present findings are interpreted as support for speech disorders as the primary explanatory constructs to guide the selection and sequencing of treatment targets within the subsystems for persons with Down syndrome. So often we see a different type of therapy being done with our children, not necessarily targeting the motor speech aspect of speech. So one common motor speech disorder in the Down syndrome population is childhood dysarthria. For many years, this is the motor speech disorder that some considered was the only motor speech disorder people with Down syndrome could have. And in the sample, Wilson's study, it showed that 37.8% of the sample had childhood dysarthria. And I think when we look at the characteristics, you're going to see why this is a common diagnosis. However, the important part to note is that the severity and the degree these symptoms occur vary hugely in each individual, and the effects on speech will differ for each person. In dysarthria, there is a weakness not defined just to speech skills. The weakness will be affecting other skills such as chewing or swallowing or difficulty controlling saliva. So dysarthria is a deficit in what we say in execution that results from impaired movement of the muscles used for speech production, including the lips, tongue, vocal folds, and or diaphragm. And that's from ASHA. ASHA is the American Speech Hearing Association. These symptoms may be observed during an oral peripheral examination, an oral mech exam, and they'll reveal weakness and poor control usually. The characteristics and severity, like I said before, will vary a lot in individuals, but you may see slow speech, differences in vocal intensity, their loudness, or monotone speech. Madeline has this a lot, and also imprecise articulation. Okay, so let's take a listen to Madeline in this little video and see if you can hear what I'm talking about.
Water? What happened to your water, Madeline? No. You threw it down, didn't you? Madeline, do you want more bite?
bites. Okay, tell me all done.
Madeline, do you want more bites?
Yes, you're all done.
Tell me all done.
Done.
Yes, you're all
Done.
done.
So we talked a little bit about childhood dysarthria of speech, and now we're going to move on to childhood apraxia of speech, sometimes called CAS. So apraxia of speech is a speech label for difficulty with planning and programming movement for our speech. So remember, dysarthria had to do with the execution of speech, and apraxia has to do with the planning and programming of the movement. Remember, also movement is key, but the movement for our speech. So our brains plan and program the movements needed for speech, including all the subset systems of speech that we've talked about previously. Remember, respiration, phonation, etc. Our brains also must judge when to move, at what speed and in what direction, and also with how much muscle contraction, all at the same time. So childhood apraxia of speech is when there is a disconnect in the ability to plan out and program movement, impacting speech production and prosody. So remember, in the study that we talked about, the Wilson study, 11.1% of the sample noted had CAS. And so, like we said, CAS is a motor speech disorder, and children have difficulty planning and coordinating and producing the sequences of sounds for speech. And it interferes with the child's ability to say sounds and to combine them into syllables and words and phrases and conversations. What you're going to see is voluntary movements for imitating sounds are difficult. Voluntary movements for speech are difficult. And increased difficulty with complexity. So as the word gets harder and more complex, the child is going to have more trouble saying those words. Okay, so the key characteristics that you're going to see in childhood apraxia of speech, you're going to see vowel errors and syllable shape errors. You're going to see distortion of vowel sounds, or you may hear that the child is completely omitting the vowel sound. This is different than other speech sound disorders. You don't typically hear vowel errors. For my daughter, Madeline, she usually says baby, but sometimes it comes out Bobby. Also in the word up, sometimes it sounds a bit more like op. You're going to see inconsistent errors on consonants and vowels in repeated productions of syllable or words. So another example for us is that sometimes Madeline says Mimi, but other times it comes out mommy, Mimi, Mimey. So there's inconsistent errors on repeated productions. Groping, you don't always see groping, but sometimes when you do, it's going to look like a child is searching for the correct placement. They're searching for that articulatory place to get started. We sometimes call this silent posturing. You're going to see stress error on words. This is super common. So for example, the word banana might sound a bit more like banana. So they're putting that stress of the word in the wrong place. Madeline does this a lot too. Transitions between sounds and syllables. You're going to see that the sounds, like the child may sound like clumsy in their speech. Their phrase or sentence might sound more segmented. They have maybe a lengthened transition time between words than usual.
No, I don't think you're sick.
And also I see a lot of kids add that schwa sound to their word. So that means the they add an extra syllable like to a word, like dog.
I'm not sick. Did you make something?
So our key takeaways here are that speech errors are inconsistent. Sometimes a word can be easy, other times it's really difficult. And also the speech is going to become harder as the length and complexity of the word increases. So a kid may say R just fine. They might say car, okay. But then when you get up to the more complex word like cartoon or cartoon on TV. Those might be harder for kids as the length and the complexity of the word increases. So I'm going to try to play this video here for you guys of Madeline. And the reason I chose this video is I noticed how much you can hear her like segmenting between each word when she says this quick phrase. Excuse the crazy hair and pajama shirt. This is real life, right? Real life video, but she had stayed home from school, and I actually have a cold as well, so I do sound a little nasally myself, but here it is.
Hey, Madeline, tell Mimi how you're feeling. How do you feel?
Sick.
You're sick?
Sick.
No, I don't think you're sick. You did have to stay home from school, but are you feeling sick?
I'm sick.
No, you're not feeling sick. You're fine.
I'm sick, Mommy.
I'm not sick.
So that part, I sick, Mommy?
Did you make something?
Pie.
You made cake? What did you make with Mommy?
Pie.
Did you make Play-Doh?
So the childhood apraxia of speech symptoms often seen in the Down syndrome population. We often see that kids omit the first sound in a word. So they may say og for dog or otter for water. They have what we call ghost words. So words appear and then they disappear in a child's speech repertoire. Sounds may be acquired in a non-typical developmental order. So they may, learn a harder sound first and not follow that typical speech sound order that we often see all over social media, right? They also might present with multiple articulation errors. They may have low muscle tone, but the tone doesn't have the direct impairment of the muscles for speech. So the low muscle tone is there, but it's not part of the childhood apraxia of speech. So can a child have dysarthria and childhood apraxia of speech? Yes, right? We saw in the study from Wilson and colleagues in 2019, in their 2019 study, that 1 in 4 of the sample population presented with both motor speech disorders. And I'm going to go over some other research that supports this. And then I also, I feel like Madeline is a pretty good example of both dysarthria and, many symptoms of childhood apraxia of speech. Her speech is characterized really with both types of errors, but here's the kicker. There are many characteristics that overlap in childhood apraxia of speech and dysarthria. Those are the fluctuating resonance, so the intermittent hyper or hyponasality, slow rate, atypical stress, reduced stress, consonant distortions, vowel errors, and voicing errors. So distinguishing between
Now put your lips together
CAS and childhood dysarthria is often a challenge. However, identifying more specific symptoms is crucial for selecting appropriate intervention strategies.
Put your yummy sound
Let's see
in.
if we can play this video here of Madeline.
Say it loud, say it
Working
loud.
hard at saying her name.
Say it loud. That was good. Say it really loud. Good. Again, put your lips together for your yummy sound. Say it loud. Now put your lips together at the beginning. Again. Put your yummy sound in. Say it loud. Say it loud.
You can hear her escape behaviors. Hi, Potty. I see your eye. So a study done by Rapella, Velleman, and Andrianopoulos in 2016 reported that children with Down syndrome appeared to have a mixed profile of motor speech disorder. So these children exhibited symptoms of both CAS and childhood dysarthria, which this is different from previous studies that assess and identify either or. Usually it identified kids with Down syndrome to have childhood dysarthria and infrequently childhood apraxia of speech. But what this study showed us, and you can see here in the table all the different motor speech characteristics for each disorder, and you can see the percentage of people with Down syndrome that reported with those symptoms. So what this study, though it is, a small study, it was a behavioral finding study, it still supports the evidence that this can exist, that people with Down syndrome can have, their speech can be characterized as having both childhood apraxia of speech and dysarthria. So, regardless of the diagnostic label, I love this quote, regardless of the diagnostic label, applied interventions must be based on the systematic inventory and analysis of the specific symptomatology observed, the motor programming and planning of motor execution systems they are impacting and effect each component has on the individual child's ability to communicate effectively. Okay, so let's take a look at this chart. Symptoms drive treatment. Let's look at a comparison of dysarthria, childhood apraxia of speech, and severe articulation disorder. The most consistent key differences I've highlighted in bold. So we know that in dysarthria, there's generally consistent errors, including the vowels. So with contrast, with childhood apraxia of speech, remember we said how vowels are inconsistent and they might be distorted or omitted. You may see the schwa in there. And then with severe articulation disorders, they don't usually have vowel errors, and their errors are also consistent with specific sounds. Dysarthria, you're going to have the swallowing is often affected. So that is one characteristic that is in bold. For childhood apraxia of speech, no swallowing concerns. Severe articulation, no swallowing concerns. In dysarthria, we're going to have weakness of the musculature, right? In childhood apraxia of speech, there's no weakness. Severe articulation disorder, no weakness. In dysarthria, rate, rhythm, and stress are disrupted in ways specifically related to the type of dysarthria. In childhood apraxia of speech, the rate, rhythm, and stress of speech are disrupted, and some groping may be present for placement. Severe articulation disorder, there's typically no disruption of rate, rhythm, or stress. In dysarthria, you may be seeing less precise connected speech than in single words. In childhood apraxia of speech, the number of errors will increase as the length of the word or the phrase increases. In severe articulation disorder, errors are generally consistent as the length of the utterance increases. Inconsistency with increased length may be noted when there is a co-occurring language impairment. Let's talk about obtaining a differential diagnosis. This is a tricky one, but the one point I want to emphasize here is that this cannot be done in one session. And I'm going to explain to you why this is the case. So to diagnose, you have to give a motor speech assessment. A motor speech assessment will help describe discriminating characteristics like the symptoms table we looked at earlier and make a differential diagnosis. It It will specify severity of the disorder and determine the length and complexity level at which the child's motor system breaks down, right? So if they're having a hard time with syllables or words or multisyllable words, phrases, a motor speech assessment will give us this information. And this will also help us know where to begin treatment. So Preston and colleagues in 2021 noted that we should be using a battery of tests for assessment, meaning we should be using many different tasks for assessment to look for certain characteristics of childhood apraxia of speech or dysarthria across many speaking tasks. So possible tasks that your SLP will probably look at are case history, definitely will be done, medical and developmental. This will be helpful for parents to send. They could send videos of your child to the SLP, like old home videos, so that your SLP can see what types of errors they were making early on in their development. An oral mech exam will be given. They may look at feeding screening if dysarthria is a question. Polysyllabic word task. So that's asking the kid to say words that are harder words and that have more than 2 syllables. A dynamic motor speech exam. So this is a big part of a motor speech assessment, and this is the part that often we feel like, at least I have felt like, that early on our kids with Down syndrome may not be able to participate in this part of the assessment because they are asked to repeat lots of words, and therapists typically will be giving the child cues to help them say the best production of the word. So they may have them repeat after them. They may have them produce the word in simultaneous production, so saying the word together. They may then utilize tactile cues, touch cues to help kids. They may ask the child to repeat the word in different ways to see how they react to cueing. They may also look at an inconsistency measure to, like we talked about earlier, to see where the breakdown is. They will definitely get a connected speech sample, meaning basically like just a sample of a child's speech during, probably a play activity, maybe in a wordless picture book. They want to get a good idea of what their speech sounds like when they're trying to have a conversation. Connected speech is what we call that. And syllable repetition task will be given. So they'll ask the child to say syllables multiple times. The assessment should be dynamic. So that's the part that we are talking about. In a dynamic assessment, the clinician uses cueing to help the child with correct production over repeated attempts. The SLP is trying to identify the child's skill level as well as their learning potential. The SLP will note cues used to help the child with accurate productions, such as direct imitation, simultaneous production, slowed rate, and then adding tactile and or gestural cues. So there are some standardized measures that the SLP may use in a motor speech assessment. And I just want to throw those out there for you guys so that you have heard these terms. But one that's used often is the dynamic evaluation of motor speech skill, and this is called the DIMS in short, or the verbal motor production assessment for children, the VMPAC, or the language neutral assessment of motor speech for young children, LAMS. There's also a new checklist called the ProCAD, and it's a great resource for SLPs to use to see the different characteristics of both childhood apraxia of speech and dysarthria and how they overlap. So for these reasons, a motor speech assessment cannot be done in one static assessment by administering one standardized test like the Goldman-Fristow. The motor speech assessment summary will give you an idea about motor execution, so it will indicate the structure, function, and physiology. The summary statement may indicate structures for speech are within normal limits or within functional limits. Both terms are used. Or it may note that there was weakness present, speed and range of motion was decreased, or coordination decreased for structures needed for speech. Physiological support will also be noted. It will be noted in the same way within normal limits, within functional limits, or impaired. The motor planning for speech will be in the report as well, and this will show the ability to sequence sounds in various contexts. So we've got syllable shapes there, CV, VC, CVC, those will all be noted. And we'll talk more about syllable shapes. Monosyllabic words with the same consonant, so they'll look at if kids are able to say words like mom, so the two consonants in the word are the same. Monosyllabic words with different consonants like mop, bisyllabic word repetition, mommy, sissy, patty. Multisyllabic word repetition, so harder words like rainbow. Repetition of words of increasing length, right? We talked about that roller skate, and they'll note where the breakdowns are. Phrase repetition of increasing length. So a comparison of automatic speech to novel speech will be noted. So can a child easily, can they count because it's that automatic speech compared to when they are trying to tell you about, what they want to play with. Those differences in how their speech comes out in an automatic way versus novel speech. The SLP will note how the child did with cueing, right? We talked about that. Immediate repetition. Did they need immediate repetition? Could they do delayed repetition? Or did they need the simultaneous production to accurately produce words? So one other task that you will likely see on a motor speech assessment summary is the diadochokinesis task, in short DDK. And this is really looking at sequential motion rate of individual syllables. So often SLPs will have a child say pa 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 pa, ta 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 ta, ka 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 ka, and they are going to be noting the rate of the speech, voicing errors, and the ability to sequence the syllables. So they'll also maybe have them do AMRs, alternating syllables such as puddika, 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 or patty cake, patty cake, patty cake, buttercup, buttercup, buttercup. And they'll be noting the rate of the speech, the voicing errors, and the ability to sequence the syllables. Sometimes voicing errors, they'll say, instead of pa, they turned it into ba, so we know that they're voicing the b sound instead of making it a p sound, a voiceless p sound. So what if your child cannot participate in a motor speech assessment? Everything I just went over, you can tell that it's a pretty complex and dynamic assessment, and it does take time. And this has been my concern for a long time with Madeline. I knew that she probably wasn't quite ready for a thorough dynamic motor speech assessment, but there are things we can do, and this is what the SLP can record information over time, and the focus can be on the results of the case history, the oral mech exam, the feeding screen, the dynamic evaluation, just a simple cueing system. We can do our best to see what types of cues help the child the most. A communication sample during play can be gathered, and we will continue to gather information from the parents through videos, speech samples, play samples, and by continuing to monitor and continuing to gather information, we can get a good idea of what the child's motor system looks like. If the child has limited speech output, it will be hard to determine if the child has dysarthria, childhood apraxia of speech, or if there's another motor speech disorder going on. But what we can use is the information that we do have to make a suspected diagnosis or a hypothesis-based diagnosis. And let me explain about the hypothesis-based diagnosis, because this was new to me and I think it's super beneficial for our kids in particular, and that is in the Apraxia Kids Conference that I was able to attend virtually thanks to the Down Syndrome Association of Central Florida. The presenters Elizabeth Murray, Shelley Velleman, Donna Thomas, Elise Baker, Claudia Abati, and Akila Shibu spoke about the hypothesis-based clinical assessment of complex cases. And this presentation, like I said, it really struck a chord with me because I believe as SLPs working with complex communicators, we can use this idea and this framework to treat the visible symptoms our individual clients have as they arise and continuously think about what we are currently seeing. It's important to use a provisional label of suspected motor speech disorder and use a motor planning approach, not a language stimulation approach, or those targeting patterns that, those approaches that are targeting patterns of errors, like phonological approaches, right? These, unfortunately, are not likely to be effective in early treatment of motor speech disorders. So, unfortunately, even with a battery of assessment tools, the answer may not always be clear-cut, right? And the best answer is to work from a hypothesis-based model. And here are some underlying questions that they proposed in the presentation that they did about hypothesis-based assessment. So what do we know? What do we think? Or what's our hypothesis? What do we want to know? How do we get that information, right? So though we may not know the exact diagnosis straight away, we can be working towards gathering these questions and answering these questions throughout treatment to better understand a child's speech deficits and how we can best plan therapy and help the child make gains. So we talked a lot about motor speech assessment, and I know that was a lot of information thrown at you, and I hope that that just gave you a kind of an overview of what an assessment looks like. And also I just want to mainly point out how it really can't be done in one session, and likely you're going to have a lot of questions for your SLP that is, you know, giving the assessment. And that's good. That's a good thing. And you'll have hopefully some framework of the different tasks that you want them to be looking at to appropriately diagnose the motor speech disorder. So now I was hoping to talk to you about treatment approaches for childhood dysarthria and also treatment approaches for childhood apraxia of speech, excuse me. So first let's talk about speech intelligibility treatment. In short, it's called SIT, and it's a dual-focused 3-week intensive treatment program. It's 6.5 hours a day, 5 days a week. Wow, that's a lot, right? I know she implements it during a summer camp, usually, and it was developed by Dr. Erica Levy, and instructions to speak with a big mouth and strong voice are given to the students, and they address the articulatory working space and vocal intensity reduction seen in many children with dysarthria. The next approach is called speech systems approach, and it's a 6-week intensive treatment program, 35 to 40 minutes, 3 days a week, and it's developed by Lindsay Pennington. This treatment targets children's control of respiratory and phonatory effort, phrase length of syllables per breath, and speech rate. And children practice coordinating exhalation and phonation, first in sustained vowels and then in spoken language tasks. Studies of the treatment by Pennington and colleagues show intelligibility gains at word level and in narrative speech, as well as positive effects of internet delivery. So this is an approach that can be given through teletherapy. Well, that's a good thing. The Lee-Silverman voice treatment, LSVT Loud, is a 4-week intensive treatment, 1 hour daily, 4 days a week, and it was developed by Lorraine Varney to improve speech production in adults with Parkinson's disease, but has also been applied to children with dysarthria. The treatment fosters healthy vocal loudness, not only to increase vocal intensity, but also to benefit across speech production systems, such as improved intelligibility. The signal treatment focus lightens the speaker's cognitive load, which along with increased repetitions of practice facilitates learning. So I think what I want to point out the most here for the approaches that have been used in childhood dysarthria is, they all involve an intensive treatment program. They all involve principles of motor learning, and we will talk more about that soon. Of course, most of these approaches have been used with kids that have cerebral palsy and they have dysarthria, but I know that the LSVT Loud program has also come out with some research specifically for people with Down syndrome and what their results were using the LSVT Loud approach, and they had good results using that approach as well. So we'll talk more about that as well. So now let's talk about the treatment approaches for childhood apraxia of speech. The ones I have listed here, these are just a few of the many different approaches that are used in treatment. The approaches marked with stars have the most research to support their effectiveness in treating CAS. Dynamic temporal and tactile cueing, also called DTTC for short, is one of the most studied. It uses functional real words selected at optimum challenge level, and it uses a small set of targets in order to get a high amount of practice trials. You also fade and add cues as the child needs them to help them maintain accurate practice trials. So they use airless learning. I've also seen this used in really young children. It can be used for kids as young as 2 years old. You usually use frequent shorter sessions to distribute practice trials and then adjust the practice schedule and adjust the elicitation method. The next one is prompts for restructuring oral muscular phonetic targets, and for short it's called prompt. And it's a multi-dimensional approach to speech production disorders. You've probably seen some therapists on Instagram using it with their clients. It's a really neat approach, and it takes a lot of training to become a prompt trained therapist. And it can be used to treat not only CAS but other speech sound disorders. But it does utilize the principles of motor learning just like DTTC does. However, the research, when I looked specifically at the approaches with evidence to support their use with childhood apraxia of speech, prompts didn't have as much evidence to support its efficacy for treating childhood apraxia of speech. Rapid syllable transition, or REST, is designed to treat childhood apraxia of speech or ataxic dysarthria in children. It's used usually for older kids, 4 to 12. So I've seen this used in some of our older population of people with Down syndrome. You use nonsense words that sound like real words but do not have meaning, allowing the child to concentrate solely on the accurate movements for sounds and the stress and the smoothness. Again, treatment sessions follow a consistent structure of training and practice. So your therapists have to be trained in this approach as well. Kaufman's speech to language protocol, the KSLP methods. I've always called it the Kaufman method. The KSLP is a new term. But it shapes the child's best approximation of words toward the full adult forms. And then you use those words in functional, expressive, and social language. The Numfield Dyspraxia program, again, like I said, this is a new program to me, but it's not a new program, but it's very highly used in the UK, and it's based on motor skills learning approach as well. And there's a particular emphasis on the motor programming skills. The therapy approach is used to treat severe speech sound disorders, including CAS. And although it is designed for children ages 3 to 7, it can be adapted for younger or older children. So I mentioned in the previous slide that some therapy approaches have more research evidence to support their use and effectiveness in treating motor speech disorders. Treatment methods supported by research tell us that there is evidence that the methods or the techniques are supported by research as effective. There are other CAS treatments that do not have the same level of evidence as those listed in the slide previously. Treatment research in CAS has expanded significantly in the past few years, but large randomized controlled studies are still needed. Many factors, though, may influence a clinician's decision to use a specific treatment method, including parent preference. So parents should be involved in this process of choosing the best treatment approach for their child. And your clinician can help guide you in this decision, explaining why they've chosen which method, which approach, how it will be implemented, and whether or not you think it's a good fit for your child. So I mentioned principles of motor learning when we were discussing therapy approaches in both dysarthria and apraxia. And what we know is that all humans learn motor skills in a certain way. And what we are calling principles of motor learning, or PML. So treatment for motor speech disorders should follow these principles carefully so that we're getting the most bang for our buck, right? It's a way to structure therapy to help us achieve the most rapid and the best response to a treatment. So there are many different ways therapy can incorporate principles of motor learning. Principles of motor learning can be incorporated in drill work. It can be incorporated in play with very specific targets and with a plan and with guidance from the SLP. The parents can incorporate PMLs at home. So to effectively treat a motor speech disorder, we must use motor-based approach, that we can implement principles of motor learning into to help the child learn complex motor control necessary to produce words and sentences. So the SLP is going to use principles of motor learning to guide the treatment. And in the next slide, we're going to go over the principles of motor learning for learning a new motor movement. So to learn a new motor plan, we need these key ingredients, so to say, incorporated into the session. We need high amounts of practice, frequent and intensive practice of a small set of speech targets. Focus is on accurate speech production, accurate speech movement. We're going to include external sensory input for speech production. That could be tactile cueing, visual cueing, auditory cues. We're going to use block practice for learning a skill. So we're going to practice those small sets of words many times Sometimes we'll say the same word over and over and over for that block practice. And then we'll start to distribute our target list of words in homework or home practice so that the child begins to generalize the motor plan. We're going to use frequent and specific feedback on speech production target. So when we are trying to help our kids learn a new motor movement and they produce a word, like Madeline often says Adeline for her name. When she does say Madeline, I give her that specific feedback. Oh, wow, I love how you put your lips together for your yummy sound. You put your lips together. That's specific feedback. Practice conditions will vary, meaning that different intonation and stress patterns will be incorporated into the drill to help develop that smooth and even speech. So you're going to say your target word. You know, we often say, let's say Madeline like you're a daddy, using your daddy voice. Or let's say Madeline with your whisper voice. Let's say Madeline with your angry voice. So those are different practice conditions that will vary. So, you know, parents can help prepare their child for principles of motor learning therapy, that specific type of therapy that we really want to accomplish in our therapy sessions. And honestly, parents do the hard work of preparing their child. So like I said, parents really do the hard work. They do the hard work at home by getting their little ones ready for this type of therapy. And there are some prerequisite skills for principles of motor learning therapy. We can't just expect any child at any age to participate in this type of therapy. So I just wanted to go over some key points that parents have the ability to help facilitate in their child. So the first one is communicative intent or motivation. So we want to help inspire the motivation to communicate. And one way we can do this is by being responsive to our children's attempts at communication. So whether or not their words are correct or we understand exactly what they're trying to tell us, we can respond in a way that helps them know that they are communicating with us. We can help them by helping them to understand imitation. So we want to start with nonverbal imitation using big body movements. Play catch back and forth with a ball. We can sing songs with movements like row, row, row your boat. We can use nursery rhymes with hand and body movements to help teach imitation skills. We want to establish joint attention and focused attention, which is a little harder. Joint attention using gestures such as pointing along with an eye gaze to show the child where to direct their focus with you. For example, look, there's a bird. You model the pointing and eye gaze as you speak. Pointing to objects the child is showing interest in is a great place to start. Focused attention is a skill that will continue to develop, and it will continue to develop as the child gets older as well, but it's a skill that we can always be working on to strengthen. We can do this by minimizing distractions, giving a definitive end to a task, starting small, and by being explicit with our child, telling them exactly what we want them to do. Eye contact is going to help a child in being successful with principles of motor learning therapy. We can help our child develop eye contact by using smiles and tickles and hugs, or maybe even silly faces, whatever your child likes. You can reinforce when your eyes meet by, giving them a tickle or smiling, being silly. You can stand in front of a swing and make eye contact while you push them or tickle their feet. Or, when they're sliding down a slide, you are looking at them intentionally in the eyes. All these things are going to help establish that good eye contact. Of course, we're not going to force a child to make eye contact. It's really not appropriate to work on eye contact strictly as a goal. You know, that's just one piece of the puzzle that will make, you know, imitating speech in a structured therapy program easier. We want to decrease tactile defensiveness. So another thing that we as parents can help our children with. So the speech therapist often will want to use tactile or touch cues on the child's face to help them feel a speech movement. And this is a great cue, right? But often our kids have tactile defensiveness for many different reasons, right? Hospitalization, feeding tubes, so many different things. But we can start to help the child get used to touch senses by using things like weighted products. We can use deep pressure. Often we want to avoid that light touch or unexpected touch. The best thing that you can do for this is to consult with your occupational therapist as how to best help your child decrease tactile defensiveness. We want to help your child develop volitional control, so with fast and slow movements and big and small movements, so that controlled movement of their body. So since the therapist will give verbal cues to help your child with speech movement, we can teach our children about big movements and small movements, fast movements and slow movements. I like to do this by using your body, like your hands growing big and then small, or your arms spread big and small, and then moving them to have them try this with their mouth, making a big mouth and a small mouth. Fast and slow movements can be illustrated with our fingers moving slowly, and then fast like they're running. And lastly, we can help them learn about what pre-practice is. We can start to introduce visuals and hand cues for different letter sounds for phonetic placement awareness. There are many videos on YouTube for phonetic placement hand cues. Speech sound cue cards on Teachers Pay Teachers. The Bajorm speech sound cue cards are wonderful for giving kid-friendly representation of speech sounds. I know a lot of therapists use those. There's also free resources online. I listed a link there for you to a website, speechlanguagetherapy.com by Carolyn Bowen, and it's a great website in general, but this specific link gives you get you to these cards, the stimulability character cards. And stimulability approach is a whole nother approach, but not necessarily for motor speech disorders, but it is a great source to print some more phonetic awareness cards. So you can see there's a picture of Baby Bear and Cheeky Chick, and there's a whole PDF that you can download for free to work on those phonetic cues. So let's talk about the key components of effective therapy. We all want effective therapy, right? The number one focus is on the movement of speech, not individual sounds. We don't need to be using an articulation approach where we're working on sounds in isolation, and then syllables, and then words, and then phrases, and then sentences, and then conversation. That's a typical articulation therapy approach. And it's not what we want for a motor speech disorder. We're not going to get enough progress using an approach like that. We also know that we need to pick functional targets, especially important for people with Down syndrome. It's important for everyone, right? We want people to be motivated because we're giving them functional, meaningful, and motivating targets that they want to practice saying. The focus should be on the accuracy of movement output. We're going to use airless learning. So that means we're going to give cues until successful. And then we're going to fade those cues to help them become independent. We want our targets to be intrinsically rewarding. We want the child to be motivated because they were understood. They have that intrinsic reward. Because our targets are functional, they can be practiced anywhere, right? Not just once a week in the therapy room with one deck of cards. Also, this will help with motor learning because practice is occurring in different places, with different people, with different emotions, right? And as the child gets better and as the targets increase, that's a natural part of the child's learning. And that's when we have motor learning, which is our overall goal. We don't just want the child to be successful in their therapy session. We want to see motor learning, which means there's generalization, they're learning this motor plan, and they're able to carry it into their daily life. We're going to choose targets at optimum challenge level. That means we're going to optimize potential for their improvement by choosing words that are at the point of difficulty that allows for enough feedback to facilitate learning but not decrease the effectiveness of therapy. So, for example, choose targets with only sounds in the child's inventory, meaning sounds the child can say, and with syllable shapes that are slightly over where the child is in connected speech. So if a child was able to produce consonant vowel combinations like to, we might try me too, or we might try I want to eat. We'll go over some more syllable shape information here shortly. We also want to remember co-articulation. And co-articulation is when is what our goal is for our speech to sound natural, right? And when we're thinking about this, it's easy to think about the way we say words like the word water, right? The T, though it's written with a T, when I say water, it sounds a lot more like a D. I don't know. Often I see, that being prompted. I don't know. Well, most kids don't say, I don't know. It sounds more like, I don't know. I do it. Things like that. Stop sounds really, that P is just a slight aspirated P. It's not P. Stop P. Stop P. We don't want to overemphasize ending sounds by accidentally adding more sound to the word. Communicate targets to those in the child's life. The siblings, teachers, therapists, we want to implement a system to share targets and what level of cueing should be used for each target. I've seen a lot of people use Google Docs, just like a quick information sharing document to the IEP team. You could do like a quick video. I often do this at the end of a lot of my sessions with my preschool students who I see at school for home practice. And then also parents know what we worked on. You can do this with a notebook system. And some people use wearable tags like the lanyard type system, a little necklace lanyard and with the piece of paper inside the tab of the lanyard, and they have like their two or three targets written on their note card. Then the teacher sees them, the parent, and they can be the paras, they can be prompted all day to really target those words. So most importantly, the practice partner needs to know what level of cueing the child is needing, and we should not be given targets that are not showing adequate progress in therapy. So we don't want to give targets that are, still requiring a lot of prompting for our kids to say, for them to take home as practice. So the targets will continue to differ over time as the child's motor speech skills improve. So let's get back to choosing our targets. We're going to choose fewer targets. This helps the child feel successful. The therapist will choose targets with your help as the parent based on the child's sound inventory, which means the sounds that the child can say. So they'll have a big checklist, say, of all the different sounds, and you can help your therapist fill that sound inventory out, or your therapist will fill that out, and then you're going to see that they're going to combine those sounds with different vowels the child can make to make syllable shapes and to make simple words. And they're going to concentrate on core and power words, because those are those words that really just are going to make a big difference in a child's life. We want to help them communicate in the most situations that they can. And then there's usually like a wish list of words, and those are going to be words that they may be hard. They might be harder words. Obviously in our case, Madeline is a hard word, and it's not necessarily the best word in that it's a little bit, not a little bit, it is, to the syllable shape is hard. It's more complex than Madeline is able to produce right now, but it is one of our wish list words, and so we're going to continue to work on it. Communicate the targets, like I said, to those in the child's life, and we're going to continue to monitor the progress to determine if gains are being made, or to determine what sorts of adjustments to the targets need to be made. So here's the magic question: how often should my child have therapy, right? Don't we always wonder as parents how long our child sessions should be, how many times a week they should be seen, all of those things. And a high treatment dosage is consistent with principles of motor learning research. Repetitive production practice is needed, therefore intensive and individualized treatment is very important. When we're thinking about our younger children, and we know that early intervention is key, the frequency and the length of the sessions, they may need to be shorter and more frequent. Teletherapy may be a good idea to get more frequent and shorter sessions. And it's important to note this point. This is, to me, the most important point here. And that is that the number of sessions, the length of the sessions, the number of trials that we're getting, those aren't necessarily the most important element to focus on. We want to focus on the quality of practice. So what's happening during the practice event is the most important piece. So how do we find a speech-language pathologist to work with our children on these skills? It's important to find an SLP who has knowledge about motor speech disorders and also knowledge of the Down syndrome behavioral phenotype. And we'll review and go over a bit more about the behavioral phenotype here in a few minutes, because I think that's an important piece that we can share with our therapists to really help our kids get effective therapy. But ASHA states that a well-trained SLP with specific experience in pediatric speech sound disorders, including motor speech disorders, should be looked for. Consider interviewing the SLP, asking about experience with motor speech disorders, ask what areas they assess, also ask about their experience working with people with Down syndrome. You can search websites like the Apraxia Kids website, which I listed the link there for you. They have an SLP directory, so you can look for those with advanced training. So there are other SLPs on the website, and that means they, obviously have some knowledge about apraxia, but there is a specific recognition to those therapists who have gone through advanced training by Apraxia kids. The good thing is that often you can find therapists to work with your child through teletherapy that have this extra training, and there are some new laws that are going to be passed here soon in 2023, I believe, from ASHA, the American Speech and Hearing Association, that is going to open a lot of doors for families as far as seeking therapists that can implement teletherapy across state lines. Because right now you can, have teletherapy, but you are limited by where your SLP holds their state license. And SLPs can have numerous state licenses, but hopefully this new law that's going to be passed soon will open the doors to a lot of families. You can also look at Child Apraxia Treatment website, and they also have a really great information on selecting a speech language pathologist. So let's talk about the trisomy 21 behavioral phenotype. I think this is such an important piece that we can share as parents with our therapist. And a lot of therapists, they may know some of these things about behavioral phenotypes in children with Down syndrome, but there are some that don't. And there's actually a lot of new research coming out that is giving us even better information that we can share. So I've done my best to summarize what I've learned, and I'm hoping that you can take this information and share it with your therapist as well. So a behavioral phenotype can be thought of as an observed set of characteristics shared by a majority of people with a common genetically caused syndrome. So there is a higher likelihood that these things will exist, but it's definitely not certain. I hate when, people lump all of our kids into one big category, and I totally get that as a parent. But these are traits that are commonly seen in the population, but not in all, right? So later development, the ability to learn words, right? To learn the words builds on earlier experiences. So the ability to hear and distinguish speech sounds. And we know that every child, including children with Down syndrome, adapts to their environment. So where children with Down syndrome struggle to develop key skills in a typical way, like kids with Down syndrome, sometimes take longer to learn to walk, say. And this is something my daughter did. She would do this like half walk, half crawl. We called it her army crawl, I think. No, not army crawl. Crab walk, I think is what we called it, because she was like on all fours, but she was almost walking, and she got around pretty well like that. But these atypical ways, these adaptive strategies that our kids often use, they're so great for in the moment. They are, I honestly think it's a really smart thing that they do to develop these skills and to get their needs met. But these strategies, they give them immediate benefits, but the same strategies, the same skills may restrict their later experiences and affect their developmental trajectory. Constraints on motor abilities in infants is likely to have cascading effects on other aspects of development, including social development. So we kind of talked about that with like the crab walk, or when babies scoot on their bottoms rather than learning to crawl. So that motor system, all those pieces that help with development can be affected. Also, just another small thing that I think about often with our kids with Down syndrome when they're little, and especially, when our kids have had heart surgery and they have restrictions on, how they can get around. And if you think about a baby and a mom and a family, and you think about the baby so often will either, be carried to another room with the family to say, answer the front door. They are seeing that communication there. They're realizing that cause and effect. The doorbell rings, somebody gets up and goes to the door. Or, different areas of the house that babies will usually, be able to crawl to discover or to get to, brother or sister. Sometimes those motor skills are hard for our kids, and it takes them a long time to get to those same levels, and so they're missing some of those communication opportunities. And so I just try to think about that and remind my parents that we can, do our best to just cart them around or move them to the room that we're going to. And I mean, I know parents do this, but it's just a thing to think about as well. All right, sorry, got on a tangent there, but infants with Down syndrome, they rely a lot on imitation, right? Imitating those around them in social situations. Again, this is really useful. It's really useful for the short term. But it can cause challenges in the long run because they're constraining the development of their independent behavior in the long run, in the long term. So here are a few important keys to share with our therapist. Strengths in visual imitation. I think we've probably all heard this one, that our kids have strengths in visual imitation. We can teach skills using shaping and prompting techniques. They may avoid opportunities to learn new skills, making poor use of skills that they have or consolidating those skills. Use speech and gestures to scaffold. So you can use speech and gestures in your shaping and prompting techniques. Frequent practice with supports. Positive motivational feedback. Purposeful and relevant activities. We've talked about this in our target selection, right? Airless learning to prevent task abandonment. And begin and end with domains of strength. So how can parents help in motor speech therapy? They can do a ton, let me tell you. Your child's SLP is your coach, your guide for your home practice. The words and phrases you practice should be words that the child is able to say correctly, consistently, and with minimal cueing. The point is to practice words in a variety of situations throughout your day. This makes the motor plan become automatic. So ask your SLP what functional targets you should be practicing. Pick 1 or 2 targets to focus on during the day. We're going to acknowledge, repeat, and model. We're going to keep practice positive and think about quality over quantity. We're going to dedicate a specific time to practice. I'll confess that our specific time to practice is usually before bed, which is probably not the most ideal time. I try to incorporate our targets in play as well as a few routines, but before bed has become one of our specific times that we practice. Share information with the therapist about the child's personality and preferences, and this can really help your SLP, and it will help your child stay motivated. And we can help our therapist understand how our children respond to frustrating situations and how they manage challenging behaviors at home, how we as parents manage these challenging behaviors. We can share that with our therapist, and that will help them in their planning of therapy. Examples of functional phrases. So here are just a few examples that are some of my favorites. I do, me too, my turn, I see, go now, I do it, I put it in, put it on. These phrases are fun to work on, especially during snack time or cooking time. Cooking is Madeline's favorite right now, so we try to incorporate some of these phrases during that time. Physical activities or movement time. Some targets could be push, go, up, down, ready, set, go. And like I said, cooking can be a great time to work on targets. Open, wash, in, hot, yum, yuck, more, wet, stir, mix. Just a few examples to help you start thinking about what targets may be fun for your child as well. We can consider having our child say their target word like 3 to 5 times before moving on with the activity. Of course, this is going to vary with each kid and their attention level at that time, but to get that repetitive speech practice in, if you can get your child to say more than one attempt at the word, it's going to be helpful. You also want to remember to vary the pitch and the loudness and the rate during multiple repetitions to say, say the word like a lion, a mouse, a bear. This is going to increase their prosody, and it's also going to keep it fun, right? But it really is to help make the motor plan more automatic. It helps ingrain that motor plan into their system. So the dreaded repeated speech practice. I don't know, maybe this is just dreaded to me, but it's gotten better. It's gotten better through the years. I remember thinking, how in the world are we ever going to get, even 3 to 5 repetitions of a word, because Madeline would say it once and move on and there was no coming back. But I've learned some tricks and I'm hoping I can share them with you guys. And that is using repetitive music for speech, repetitive books for speech, and using games that have a lot of pieces to them, so that each time they say their target, you are giving them a piece to add to their game. So I'm going to share some of my favorite books and music and games in the next few slides. So yes, do you want to build a snowman? That was one of my daughter's favorite songs for a really long time. She was obsessed with Elsa and Frozen. And one day I just took a second to write down some words that are sung often in the song so that we could pick a few simple syllable-shaped words to focus on when we sang. Remember, you can just pick 2 or 3 words and focus on those. One of my favorite tricks I've learned when implementing songs into speech practice is to slow the music down. You can do this really easy on YouTube. I have a tutorial on my Instagram page at Down Syndrome Speech if you are interested and want to, if you don't know how to do this already. Probably a lot of people do, but just in case, it just makes it that much easier to practice speech in a super low pressure and enjoyable way. So especially helpful for speech practice in those with Down syndrome is to make personal books with the child's targets. We can highlight their target in some way with bold writing, or if you were recording your book, you can do this auditorily, presenting it with acoustic highlighting. You can use video modeling. This is a great strategy and usually really motivating for people with Down syndrome. Find a friend or a sibling that will model the child's target words for you in a video and send them to you, and then you can have a little collection of their target words and their friend says them, and then they say them. You can utilize music and or melodic intonation. So we're going to slow the music down, maybe add gestures. We can use choral singing, so singing it together, just like that simultaneous production cue. We can consider using a closed set technique.
Outside.
So, say some of the phrase and
Madeline
a
is
little part of it off.
outside.
Obviously, their target word. So no
Boone
more monkeys
is
jumping on the.
outside.
And obviously,
Claire
target word
is
would be bed.
outside.
So I wanted to show
Owen
you a quick
is
example
outside.
of one of our personal books that we made.
Mommy
and
is outside.
I've shared this on Instagram before.
Daddy is
the app Special
outside.
Stories. It's
We
a great
love to
app
go
to use to make personal
outside.
books because it's just super user friendly and quick. So you can upload your pictures directly from your phone, make the book, and then save it to your phone or your iPad. You can also print it as a PDF, and it keeps like a library of all the books that you have made. So here's one of ours.
Outside. Madeline is outside. Boone is outside. Claire is outside. Owen is outside. Mommy is outside. Daddy is outside. We love to go outside.
So I wanted to share a few tips from our occupational therapist friends for engaging children in speech practice. One is try doing speech work while the child is on their stomach. So they're laying on their stomach and you're down on the ground and the therapist would be in front of them. This gives the child deep pressure and it also brings their attention down to the speaker and maybe away from all the distracting things in their environment. It can be less distracting and good for the nervous system. Take movement breaks. This is big, huge, helpful for my daughter Madeline. Use weighted blankets or other weighted products during therapy. You can use silly glasses or stickers on the face to bring attention to the speaker's face, to the therapist's face. And pair challenging work with simple activities. So when you're working on those new motor plans, you want to keep the activity that you are doing alongside that speech work as simple as possible. So there are some games that are way too complex to try to implement during speech therapy. Keep it super simple. Throw a beanbag. Hop to a square. Whatever is motivating for the child. So I've talked a little bit about syllable shapes, and remember those are various combinations of vowels and consonants that are combined to make a syllable, word, phrase. And this is just a simple chart that shows you the progression of syllable shape development in children. And I'm sure you would guess that it starts with the word shapes like ooh, ah. Those are V shapes. Then we have C shapes like and sh, s. CV, me, hi, we, to, no. And you can follow the chart and see the progression of development in syllable shapes. But I thought this might be helpful for parents to have just a visual there of what progression of the syllable shapes looks like in children. So these are some of my favorite words by syllable shape that can be implemented into lots of different play routines or routines in your household and maybe in some music. but I just wanted to give you some of my go-to words that I often target first with kids with motor speech disorders. Also, we will never just be working on one syllable shape. We want to always be varying the child's syllable shape so that they're learning new motor plans, but we want to keep it at that optimum challenge level. If you remember, we talked about that before, just one step ahead of what is very easy for them. So you'll also combine syllable shapes to make phrases, to make simple phrases. Obviously, you could do hi mommy, hi daddy, or puppy on, go puppy, different things like that. We're going to talk about some of my favorite play activities and speech targets next. So play is a great time to practice speech. We can choose words that are easily implemented into your child's favorite play routine, favorite play scheme that are both functional and motivating. And here are just a few of my favorites, a few of Madeline's favorites, I should say, that we then have picked some syllable-shaped words that can be practiced during these play routines. And remember, you just want to pick 2 or 3 and keep them at the forefront of your mind. Maybe write them down. Some parents like to have a dry erase marker board that has the child's targets written down so that they can just have them as a reference to quickly remind them of their child's targets. Also, maybe if your child has babysitters in and out, or grandparents, even older siblings can help with this. So when you're playing, you're just going to use them. Acoustic highlighting, meaning you're going to bring attention to your mouth. You're going to make those targets super salient for them to hear, and you may, depending on what level they're at, bring attention to your mouth and prompt their production. And these plus a few more are in the parent resource PDF that I'm sharing with everyone at the end of the presentation. But obviously these are Play Kitchen simple syllable shaped words and Play-Doh activity simple syllable shaped words. So I hope this is helpful to see how we can implement this sort of work into play. So we are nearing the end of our presentation. Thank you guys for sticking with me this long. I know it's been a lot of information. I hope it's been helpful. I just wanted to leave you with some useful links. As a parent and as a therapist, I think all of these are valuable links to share. We've got the Apraxia Kids Parent Portal. It is full of information, obviously specific to apraxia, but as we've learned today, there is some information that's going to help our kids with motor speech disorders in general there on that website. The free building speech cards. This is an awesome resource that is from the Augustana College, and I shared the link below to the speech cards. Again, they're free cards and they're separated by syllable shape. So, of course, I'm not promoting that drill card work as the most effective strategy for our kids, but you can, as a parent, get an idea of what those targets might look like. Then how to find an SLP with extra training and knowledge. We've talked about that, but there is the link directly to the parent information on Apraxia Kids. The LSVT Loud research paper on using that approach. Remember, we talked about LSVT Loud as an approach used in treating childhood dysarthria, and this is the paper I referenced that is specifically in regards to the DS pediatric population. And then an apps list. So this was provided by the Apraxia Kids website as well. I thought you might find that helpful since sometimes our kids do enjoy the tablets or the iPads, and there are a few decent apps out there that can help with some speech work when appropriate. And then the education abbreviations. So I like this link here called Alphabet Soup Glossary, and it's from, again, Apraxia Kids, but it has tons of abbreviations that we often run across as parents in our journeys with our kids that you might find useful. So here is a peek at the parent PDF that I made for you guys that you can download at the end of the presentation. So there's a glossary of terms, a lot of the terms that we've used in this presentation and that you may hear your therapist use. The syllable progression chart, my favorite syllable shapes, and some of the play syllable shapes, and repetitive books, repetitive songs, toys that we use often, the apps list for motor speech disorders, and then the behavioral phenotype. And then I wanted to share this song just for fun. This is one of my favorite songs to introduce mouth movement, vowel shapes with our little kids.
Look up in the tree, a coconut is what I see. Climb to the top, and what do you think? Crack it open and take a drink.
I won't say the whole thing, but this is a little clip. I love that they show the kids' mouths, and then as the song continues, to make it even more fun, they show the monkey's mouth making these different mouth shapes. So that's just a fun little song. You can keep watching if you want, but it was one of Madeline's favorites when she was a toddler. So thought I'd share it with you guys too. Okay, so in summary, we have learned that speech characteristics of individuals with Down syndrome are consistent with motor speech disorders. Down syndrome motor speech characteristics may include symptoms of childhood apraxia of speech, childhood dysarthria, or both. Treatment for motor speech disorders should incorporate principles of motor learning and utilize multimodal cueing. The focus of treatment should be on movement of speech and not individual sounds. We want to monitor progress and work from the what is the dominant problem requiring therapy. Make this the priority. Target selection should involve parents, and targets should be functional, motivating, and give kids words for their favorite things, their favorite people, as well as for a range of communicative purposes. So we don't want to give them all, labels for things. We want them to be able to reject and protest, join, all of those things. We've learned that neural pathways are complex, right? And they overlap, and often in young children and in kids that are more impaired. The speech deficits can be a little of this and a little of that, and that is why a comprehensive assessment is so important. We must understand the child's profile, understand the child's strengths and areas of need for a diagnosis and for choosing a therapeutic approach. And lastly, we just want to make sure that our therapists know about the Down syndrome behavioral phenotypes, and so that they can plan effective therapy for our kids. Feel free to share the graphic that I made that just describes more about the behavioral phenotypes in Down syndrome, and it is included in the parent PDF that you can download at the end of the presentation. So I'll leave you with this quote by Libby Kuman, which I just love, and it's, "Development takes place over time. Development is influenced by our learning opportunities. It's not fixed by an extra chromosome. Development can be changed." And thank you all for listening. I really hope this discussion was helpful. A special thank you to the Down Syndrome Association of Central Florida and to Elaine Otto, my sweet friend, for inviting me to be here with you all. Please know I am here for you. Please reach out with any questions. You can follow my colleague Jennifer Gray and I on Instagram at Down Syndrome Speech, where we hope to continue important discussions on speech and language development in people with Down syndrome by providing useful information and tips for parents, as well as offer consultations to families who are interested. Again, don't forget to download your parent PDF, and take care, my fellow T21 families. Thanks again.